Welcome, future doctors, to another Uber School production. I'm Pete, and today we're diving deep into the fascinating world of renal pathology. Are you ready to conquer this crucial topic for your USMLE Step 1?
You bet, Pete. I'm Crash, and I'm excited to break down these complex kidney concepts. Remember, folks, our goal is to make sure every single one of you passes this test with flying colors.
That's right, Crash. We're not just here to teach, we're here to ensure success. So let's start with the basics of glomerular diseases. Can you kick us off with minimal change disease?
Absolutely, Petey. Minimal change disease is like a ninja attack on your kidneys. It's sneaky because under light microscopy, everything looks normal. But electron microscopy reveals the true culprit, podocyte foot process effacement.
Great analogy, Crash. And what's the classic presentation?
Picture this. A young child suddenly develops edema, especially around the eyes and legs. They're peeing out massive amounts of protein. We're talking nephrotic range proteinuria, which is more than 3.5 grams per day. This leads to hypoalbuminemia and hyperlipidemia.
Excellent breakdown. Now here's a quick USMLE style question for our listeners. A 6-year-old boy presents with sudden onset of periorbital edema and abdominal distension. Your analysis shows 4 plus protein, but no blood. Serum albumin is 2.0 grams per deciliter. What's the most likely diagnosis?
Ooh, I love a good brain teaser. Take a moment to think about it, folks. Brief pause. All right, the answer is minimal change disease. The sudden onset, nephrotic syndrome presentation, and lack of hematuria in a child all point to this diagnosis.
Spot on, Crash. And what's the good news about minimal change disease?
The good news is that it's highly responsive to steroids. It's like giving those ninja podocytes a taste of their own medicine. Most patients respond within 8 weeks of treatment.
Excellent. Now, let's move on to a trickier condition, focal segmental glomerulosclerosis, or FSGS. What's the key difference here?
FSGS is like minimal change disease's evil cousin. Under light microscopy, you'll see sclerosis in some, but not all, glomeruli, hence the name focal and segmental. It's a more serious condition with a poorer prognosis.
Right, you are. And it's important to note that FSGS can be primary or secondary to other conditions like HIV, obesity, or drug use. Now let's talk about the presentation.
FSGS typically presents with nephrotic syndrome, just like minimal change disease. But here's the kicker, it's often resistant to steroid therapy. You might also see some hematuria and hypertension, which you don't typically get with minimal change.
Excellent point, Crash. Now, here's another USMLE style question. A 40-year-old man presents with edema and proteinuria. Kidney biopsy shows focal sclerosis of some glomeruli. He doesn't respond to steroid therapy. What's the most likely diagnosis?
All right, future doctors, put your thinking caps on. Brief pause. The answer is FSGS. The age, biopsy findings, and steroid resistance all point to this diagnosis.
Spot on, Crash. Now let's move on to membranous nephropathy. This one's a real troublemaker.
Oh boy, membranous nephropathy is like the master of disguise in the kidney world. It's characterized by subepithelial immune complex deposits. On electron microscopy, you'll see this cool spike and dome appearance.
Great description, Crash. And what's the key autoantibody associated with membranous nephropathy?
That would be the PLA2R autoantibody. It's like the smoking gun in about 70% of primary membranous nephropathy cases. Remember this for your exams, folks.
Excellent point. Now, let's talk about the clinical presentation. What should our future doctors be on the lookout for?
Well, Pete, membranous nephropathy typically presents with full-blown nephrotic syndrome in adults. We're talking massive proteinuria, edema, hypoalbuminemia, and hyperlipidemia. But here's a twist. It can also be secondary to other conditions like lupus, hepatitis B, or certain medications.
Great breakdown, Crash. Now here's another USMLE style question for our listeners. A 50-year-old man presents with edema and frothy urine. Urinalysis shows 4 plus protein. Kidney biopsy reveals subepithelial immune complex deposits and a spike and dome appearance on electron microscopy. What's the most likely diagnosis?
Ooh, I love these questions. All right, future doctors, think it through. Brief pause. The answer is membranous nephropathy. The age, nephrotic presentation, and classic biopsy findings all point to this diagnosis.
Excellent, Crash. Now let's shift gears a bit and talk about a condition that bridges the gap between nephrotic and nephritic syndromes, membranoproliferative glomerulonephritis, or MPGN.
MPGN, the chameleon of kidney diseases. It's like the kidney decided to throw a party and invited both nephrotic and nephritic syndromes. This condition is characterized by mesangial proliferation and thickening of the glomerular basement membrane.
Great introduction, Crash. Can you break down the different types of MPGN for our listeners?
Absolutely, Pete. There are 3 types of MPGN. Type 1 is associated with immune complex deposition. Type 2, also known as dense deposit disease, is associated with abnormal complement activation. And type 3 is a variant of type 1.
Excellent. Now, what's the hallmark appearance of MPGN on light microscopy?
That would be the famous tram track appearance. It's like the glomerular basement membrane decided to lay down some railroad tracks. This is due to the splitting of the basement membrane and the interposition of mesangial cells.
Great analogy, Crash. Now, let's focus on type 2 MPGL for a moment. What's the key association here?
Type 2 MPGN, or the dense deposit disease, is associated with C3 nephritic factor. This is an autoantibody that stabilizes C3 convertase, leading to uncontrolled activation of the alternative complement pathway. It's like the complement system got stuck in overdrive.
Excellent explanation. Now, here's another USMLE style question. A 25-year-old woman presents with hematuria, proteinuria, and hypertension. Kidney biopsy shows a tram track appearance on light microscopy and dense deposits in the glomerular basement membrane on electron microscopy. What's the most likely diagnosis?
All right, future doctors, time to put those neurons to work. Brief pause. The answer is type 2 MPGN, or dense deposit disease. The mixed nephrotic presentation, tram track appearance, and dense deposits are classic for this condition.
Spot on, Crash. Now let's move on to a condition that often presents with a very specific type of hematuria, IgA nephropathy, also known as Berger's disease.
IgA nephropathy, the sneaky infiltrator of the kidney world. This condition is characterized by mesangial IgA deposits. It's like the IgA decided to throw a party in the mesangium and forgot to clean up afterwards.
Great analogy, Crash. Now, what's the classic presentation of IgA nephropathy?
The classic presentation is synpharyngitic hematuria. It's like the patient's kidneys decided to join in on the upper respiratory infection fun. They'll often notice cola-colored urine a day or 2 after the onset of a sore throat or cold.
Excellent description. And what about the long-term prognosis of IgA nephropathy?
Well, Pete, IgA nephropathy is a bit of a wild card. Some patients have a benign course with occasional episodes of hematuria, while others can progress to end-stage renal disease over 10 to 20 years. It's like a kidney lottery. You never know quite what you're going to get.
Great explanation, Crash. Now, here's another USMLE-style question. A 30-year-old man presents with recurrent episodes of tea-colored urine following upper respiratory infections. Kidney biopsy shows mesangial IgA deposits. What's the most likely diagnosis?
Ooh, I love these clinical vignettes. All right, future doctors, what's your diagnosis? Brief cause. The answer is IgA nephropathy. The recurrent synpharyngitic hematuria and mesangial IgA deposits are classic for this condition.
Excellent, Crash. Now let's shift gears and talk about a condition that often follows a specific type of infection, post-streptococcal glomerulonephritis.
Post-strep GN, the uninvited guest that shows up weeks after the strep party. This condition typically occurs 1 to 3 weeks after a streptococcal infection of the throat or skin. It's like the strep bacteria left a time bomb in the kidneys.
Great introduction, Crash. Can you describe the classic presentation?
Sure thing, Pete. Post-strep GN typically presents with the classic nephritic syndrome triad, hematuria, proteinuria, and hypertension. Patients often have edema and decreased urine output, too. It's like their kidneys decided to go on strike.
Excellent description. Now, what's the characteristic finding on kidney biopsy?
On biopsy, you'll see the classic lumpy-bumpy appearance of subepithelial immune complex deposits. It's like someone sprinkled little bumps all over the glomerular basement membrane. These deposits are made up of streptococcal antigens and host antibodies.
Great explanation, Crash. Now here's another USMLE style question. A 10-year-old boy presents with edema, hematuria, and hypertension 2 weeks after a strep throat infection. What's the most likely diagnosis?
All right, future doctors, time to put those clinical reasoning skills to work. Brief cause. The answer is post-streptococcal glomerulonephritis. The timing after a strep infection and the classic nephritic presentation are dead giveaways.
Spot on, or Crash. Now let's talk about a more serious and rapidly progressive form of glomerulonephritis. Rapidly progressive glomerulonephritis, or RPGN.
Oh boy, RPGN is like the Usain Bolt of kidney diseases. It moves fast and can cause serious damage if not caught quickly. This condition is characterized by rapid loss of kidney function, usually over days to weeks.
Great analogy, Crash. What's the key histological finding in RPGN?
The hallmark of RPGN is the presence of crescents on kidney biopsy. These crescents form when the glomerular basement membrane breaks and inflammatory cells invade the Bowman's space. It's like the glomerulus is trying to grow a mohawk.
Excellent description. Now, can you break down the different types of RPGN for our listeners?
Absolutely, Pete. There are 3 types of RPGN. Type 1 is anti-GBM disease, also known as Goodpasture's syndrome. Type 2 is immune complex mediated, and type 3 is pauci-immune, which is usually associated with ANCA-associated vasculitis.
Great breakdown, Crash. Now, let's focus on anti-GBM disease for a moment. What's the key autoantibody involved here?
In anti-GBM disease, the key player is an autoantibody against the alpha-3 chain of type 4 collagen in the glomerular basement membrane. It's like the immune system decided the GBM was public enemy number 1.
Excellent explanation. Now, here's another USMLE style question. A 25-year-old man presents with hemoptysis, hematuria, and rapidly declining kidney function. Anti-GBM antibodies are positive. What's the most likely diagnosis?
Ooh, this is a good one. All right, future doctors, what's your diagnosis? Brief cause. The answer is Goodpasture's syndrome, or anti-GBM disease. The combination of pulmonary and renal symptoms with positive anti-GBM antibodies is classic for this condition.
Excellent, Crash. Now, let's shift gears a bit and talk about acute kidney injury, or AKI. This is a crucial topic for the USMLE and for clinical practice.
Absolutely, Pete. AKI is like a sudden thunderstorm hitting the kidneys. It's defined as an abrupt decrease in kidney function, resulting in the accumulation of waste products and fluid imbalance.
Great analogy, Crash. Can you break down the different types of AKI for our listeners?
Sure thing, Pete. There are 3 main types of AKI: pre-renal, intrinsic, and post-renal. Pre-renal AKI is like the kidneys are trying to work, but they're not getting enough blood flow. Intrinsic AKI is when there's actual damage to the kidney tissue. And post-renal AKI is like there's a traffic jam in the urinary tract, backing everything up.
Excellent breakdown. Now, what are some key diagnostic tools for differentiating between these types of AKI?
Great question, Pete. 2 crucial diagnostic tools are the bione/creatinine ratio and the fractional excretion of sodium, FeNA. In pre-renal AKI, you'll typically see a high bun/crossing ratio greater than 20:1 and a low FeNA less than 1%. It's like the kidneys are desperately trying to hold on to every drop of fluid and electrolytes.
Excellent explanation, Crash. Now let's focus on a specific type of intrinsic AKI, acute tubular necrosis, or ATN. What causes this condition?
ATN is like a 1-2 punch to the kidney tubules. It can be caused by ischemia, not enough blood flow, or toxins. Ischemic ATN often occurs in situations of shock or severe dehydration. Toxic ATN can be caused by medications like aminoglycosides or contrast dye, or by substances like myoglobin in rhabdomyolysis.
Great description. What's a key urinary finding in ATN?
In ATM, you'll often see muddy brown casts in the urine. It's like the damaged tubular cells decided to form little rafts and float down the urinary stream. These casts are pathognomonic for ATM.
Excellent point, Crash. Now here's another USMLE style questions. A 65-year-old man undergoes coronary artery bypass surgery. 2 days later, his creatinine has doubled, and urinalysis shows muddy brown casts. What's the most likely diagnosis?
All right, future doctors, put on your diagnostic hats. Brief pause. The answer is acute tubular necrosis. The timing after major surgery and the presence of muddy brown casts are classic for ischemic ATN.
Spot on, Crash. Now let's move on to chronic kidney disease, or CKD. This is a major public health issue and a crucial topic for the USMLE.
You're absolutely right, Pete. CKD is like a slow-motion train wreck for the kidneys. It's defined as kidney damage or decreased GFR for 3 months or more, regardless of the cause.
Great description, Crash. Can you break down the stages of CKD for our listeners?
Sure thing, Pete. CKD is staged based on GFR. Stage 1 is normal GFR greater than 90 milliliters per minute with evidence of kidney damage. Stage 2 is mildly decreased GFR 60 to 89 milliliters per minute. Stage 3 is moderately decreased GFR 30 to 59 milliliters per minute. Stage 4 is severely decreased GFR 15 to 29 milliliters per minute. And stage 5, also known as end-stage renal disease, is GFR less than 15 milliliters per minute.
Excellent breakdown. Now, what are some key complications of CKD that our future doctors need to be aware of?
Great question, Pete. The complications of CKD are like a domino effect throughout the body. You've got anemia due to decreased erythropoietin production, bone disease due to secondary hyperparathyroidism, hypertension, fluid overload, electrolyte imbalances, and increased cardiovascular risk. It's like the kidneys are the body's multitaskers, and when they start failing, everything feels the impact.
Excellent explanation, Crash. Now, let's focus on end-stage renal disease for a moment. What are the main treatment options?
For ESRD, we've got 2 main options, dialysis or transplantation. Dialysis is like hiring an external cleaning service for the blood. It can be done through hemodialysis or peritoneal dialysis. Transplantation is like getting a brand new kidney installed. Each option has its pros and cons, and the choice often depends on various patient factors.
Great analogy, Crash. Now here's another USMLE style question. A 50-year-old man with a 20-year history of diabetes presents with fatigue, nausea, and pruritus. His creatinine is 6.5 milligrams per deciliter, and his GFR is 12 milliliters per minute. What stage of CKD is he in?
Ooh, this is a good one. All right, future doctors, what's your diagnosis? Brief pause. The answer is Stage 5 CKD or end-stage renal disease. The GFR of 12 milliliters per minute puts him squarely in Stage 5, and his symptoms are consistent with uremia.
Excellent, Crash. Now let's shift gears and talk about 2 important syndromes, nephrotic and nephritic syndrome. These are crucial concepts for understanding many kidney diseases.
Absolutely, Pete. Nephrotic and nephritic syndromes are like the dynamic duo of kidney presentations. They're not specific diseases, but rather patterns of glomerular injury that can be caused by various conditions.
Great introduction, Crash. Can you break down the key features of nephrotic syndrome for our listeners?
Sure thing, Pete. Nephrotic syndrome is characterized by massive proteinuria greater than 3.5 grams per day, hypoalbuminemia, edema, and hyperlipidemia. It's like the glomerular filter has huge holes in it, letting all the protein leak out. This leads to a cascade of effects throughout the body.
Excellent description. And what about nephritic syndrome?
Nephritic syndrome is a bit different. It's characterized by hematuria, proteinuria, usually less than 3.5 grams per day, hypertension, and often oliguria. It's like the glomeruli are inflamed and angry, leading to blood in the urine and decreased urine output.
Great explanation, Crash. Now, can you give us some examples of conditions that typically present with nephrotic syndrome?
Absolutely, Pete. For nephrotic syndrome, think of the primary glomerular diseases, minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. You can remember these with the mnemonic My Foot Massager, minimal change, FSGS, membranous.
Excellent mnemonic, Crash. And what about nephritic syndrome?
For nephritic syndrome, think of conditions like post-streptococcal glomerulonephritis, IgA nephropathy, and rapidly progressive glomerulonephritis. You can remember these with the mnemonic PIRATE, post-strep, IgA, rapidly progressive, anti-GBM, and other causes.
Great mnemonics, Crash. These will definitely help our listeners remember these important associations. Now, let's move on to renal tumors. This is another crucial topic for the USMLE.
Absolutely, Pete. Renal tumors are like the unwanted guests at the kidney party. The most common adult renal tumor is renal cell carcinoma, or RCC. It's like the kidney cells decided to go rogue and start their own rebel faction.
Great analogy, Crash. Can you break down the different subtypes of RCC for our listeners?
Sure thing, Pete. The main subtypes of RCC are clear cell, the most common, papillary, and chromophobe. Clear cell RCC is associated with mutations in the VHL gene. It's like the cell's growth brakes got cut. Papillary RCC has two types and often appears multifocal. Chromophobe RCC tends to have a better prognosis.
Excellent breakdown. Now, what are some key paraneoplastic syndromes associated with RCC?
The paraneoplastic syndromes of RCC, it's like the tumor is a prankster, causing mischief throughout the body. You might see polycythemia due to erythropoietin production, hypercalcemia due to PTHrP production, or hypertension due to renin production. It's important to remember these because RCC can often present with symptoms from these syndromes rather than local symptoms.
Great explanation, Crash. Now, let's shift to pediatric renal tumors. What's the most common one?
The most common pediatric renal tumor is Wilms tumor, also known as nephroblastoma. It's like the kidney never quite grew up and decided to form a tumor instead. Wilms tumor is associated with mutations in the WT1 gene.
Excellent. And what are some syndromes associated with Wilms tumor?
Great question, Pete. Wilms tumor is associated with several syndromes, including WAGR syndrome, Wilms tumor, aniridia, genitourinary anomalies, and mental retardation, and Denise-Drash syndrome. It's like these syndromes are the tumor's partners in crime.
Great explanation, Crash. Now here's another USMLE style question. A 60-year-old man presents with hematuria, flank pain, and unexplained polycythemia. CT scan shows a 5 centimeters mass in the left kidney. What's the most likely diagnosis?
I love these clinical scenarios. All right, future doctors, what's your diagnosis? Brief pause. The answer is renal cell carcinoma. The classic triad of hematuria, flank pain, and palpable mass is present, plus we've got that paraneoplastic polycythemia. It's like the tumor is waving a big red flag saying, "I'm here!"
Excellent, Crash. Now let's talk about a major cause of chronic kidney disease, diabetic nephropathy. This is a crucial topic given the high prevalence of diabetes worldwide.
Absolutely, Pete. Diabetic nephropathy is like a slow-motion train wreck for the kidneys. It's the leading cause of end-stage renal disease in many countries. The pathogenesis involves a complex interplay of hyperglycemia, hemodynamic changes, and various growth factors.
Great introduction, Crash. Can you break down the stages of diabetic nephropathy for our listeners?
Sure thing, Pete. Diabetic nephropathy progresses through several stages. It starts with glomerular hyperfiltration and hypertrophy, then moves to microalbuminuria, overt proteinuria, and finally to end-stage renal disease. It's like the kidneys are slowly losing their filtration ability, one nephron at a time.
Excellent breakdown. What are some key histological features of diabetic nephropathy?
Great question, Pete. The hallmark histological features of diabetic nephropathy are mesangial expansion and thickening of the glomerular basement membrane. In advanced stages, you might see the classic Kinnell-Steele-Wilson nodules. It's like little nodular speed bumps in the glomeruli. You'll also see hyaline arteriolosclerosis, which is like the blood vessels got covered in a thick, gooey substance.
Excellent description, Crash. Now, what's the significance of microalbuminuria in diabetic nephropathy?
Microalbuminuria is like the canary in the coal mine for diabetic nephropathy. It's often the earliest detectable sign of kidney damage in diabetics. Finding microalbuminuria should prompt aggressive management to slow the progression of kidney disease. It's like catching the train wreck in slow motion and trying to apply the brakes.
Great analogy, Crash. Speaking of management, what are some key strategies for managing diabetic nephropathy?
The management of diabetic nephropathy is like a multi-pronged attack, Pete. First and foremost is tight glycemic control. Keeping that blood sugar in check is crucial. Next, you want to control blood pressure, often using ACE inhibitors or ARBs. These drugs are like kidney bodyguards, protecting against further damage. You also want to manage other cardiovascular risk factors like hyperlipidemia. And of course, lifestyle modifications like smoking cessation and dietary changes are important.
Excellent breakdown, Crash. You're right, managing diabetic nephropathy is a complex process that requires a multifaceted approach. Now here's another USMLE style question. A 55-year-old man with a 15-year history of type 2 diabetes presents for his annual checkup. His urine albumin to creatinine ratio is 45 milligrams per gram. What stage of diabetic nephropathy is he likely in?
Ooh, this is a good one. All right, future doctors, put your thinking caps on. Brief pause. The answer is microalbuminuria stage. An albumin to creatinine ratio between 30 to 300 milligrams per gram indicates microalbuminuria. It's like the kidneys are starting to leak, but it's not a full-blown flood yet.
Spot on, Crash. Now let's shift gears and talk about some congenital kidney disorders. These are important for understanding pediatric nephrology and can sometimes present in adults too.
Absolutely, Pete. Congenital kidney disorders are like nature's plumbing mistakes. One of the most well-known is polycystic kidney disease, or PKD. It's like the kidneys decided to grow water balloons instead of normal tissue.
Great analogy, Crash. Can you break down the different types of PKD for our listeners?
Sure thing, Pete. There are two main types of PKD, autosomal dominant, ADPKD, and autosomal recessive, ARPKD. ADPKD is more common and typically presents in adulthood. It's caused by mutations in the PKD1 or PKD2 genes. ARPKD is rarer and presents in infancy or childhood. It's caused by mutations in the PKHD1 gene.
Excellent breakdown. What are some key clinical features of ADPKD?
ADPKD is like a grab bag of symptoms, Pete. The classic triad is kidney cysts, liver cysts, and intracranial aneurysms. Patients might present with flank pain, hematuria, or hypertension. They're also at increased risk for urinary tract infections and kidney stones. It's like their kidneys are a minefield of potential problems.
Great description, Crash. Now, let's talk about another congenital disorder, renal agenesis. What's the deal with this condition?
Renal agenesis is like the kidney never got the memo to show up. It can be unilateral or bilateral. Unilateral renal agenesis is often asymptomatic, the other kidney just picks up the slack. But bilateral renal agenesis is a whole different ballgame. It leads to Potter sequence, which is characterized by oligohydramnios, not enough amniotic fluid, and distinctive facial features. It's like the baby's development got derailed from the very beginning.
Excellent explanation, Crash. Can you elaborate on the facial features seen in Potter sequence?
Sure thing, Pete. The facial features in Potter sequence are often described as Potter facies. You'll see a flattened nose, recessed chin, and large, low-set ears. It's like the lack of amniotic fluid squished the baby's face. You'll also see limb deformities and pulmonary hypoplasia due to the lack of space in the uterus.
Great description, Crash. Now, let's talk about another congenital anomaly, horseshoe kidney. What's unique about this condition?
Horseshoe kidney is like the kidneys decided to play horseshoes and got stuck together. It's a condition where the lower poles of the kidneys are fused, creating a U-shaped structure that looks like a horseshoe. It's the most common renal fusion anomaly.
Excellent analogy, Crash. What are some clinical implications of horseshoe kidney?
Well, Pete, horseshoe kidney is often asymptomatic, but it can lead to some issues. The abnormal position can cause urinary obstruction and increase the risk of kidney stones. There's also an increased risk of certain tumors, like Wilms tumor in children and transitional cell carcinoma in adults. It's like the horseshoe shape makes the kidneys more vulnerable to certain problems.
Great explanation, Crash. Now here's another USMLE style question. A newborn presents with bilateral flank masses, respiratory distress, and distinctive facial features, including a flattened nose and low-set ears. What's the most likely diagnosis?
Ooh, this is a tough one. All right, future doctors, what's your diagnosis? Brief pause. The answer is autosomal recessive polycystic kidney disease, ARPKD, with Potter sequence. The bilateral flank masses suggest enlarged, cystic kidneys, and the facial features are classic for Potter sequence. It's like the baby's kidneys went into overdrive with cyst production, leading to a cascade of problems.
Excellent, Crash. Now let's wrap up our discussion with a brief overview of the approach to a patient with suspected kidney disease. What are some key points our future doctors should remember?
Great question, Pete. When approaching a patient with suspected kidney disease, it's like being a detective. First, you want to gather all the clues from the history and physical exam. Look for risk factors like diabetes, hypertension, or family history of kidney disease. Check for signs of fluid overload or uremia.
Excellent start, Crash. What about laboratory tests?
Lab tests are like your magnifying glass in this detective work, Pete. Always check the basics: serum creatinine, BUN, electrolytes, and a urinalysis. The urinalysis is particularly important. It can tell you if there's protein, blood, or casts in the urine. If you suspect glomerular disease, check complement levels and autoantibodies. And don't forget imaging studies. Ultrasound can give you a lot of information about kidney size and structure.
Great breakdown, Crash. And what about kidney biopsy? When should our future doctors consider this?
Kidney biopsy is like the final piece of the puzzle, Pete. It's not always necessary, but it can be crucial in certain situations. Consider a biopsy if you're dealing with unexplained acute kidney injury, nephrotic syndrome in adults, or suspected glomerulonephritis. It's also important in evaluating transplant rejection. Remember, though, that biopsy carries risks, so the potential benefits should always outweigh the risks.
Excellent point, Crash. Now, before we wrap up, I can't help but remember a story about your old pal, Marcus Cooper. Didn't he have some crazy kidney-related adventure?
Oh man, Pete, you won't believe this. Marcus Cooper, that genius running for president in 2036, once claimed he could diagnose kidney diseases just by tasting urine. He said he developed this skill after accidentally drinking a urine sample thinking it was apple juice during a marathon study session in med school. The craziest part? He was right 9 times out of 10 in a blind test. Of course, no one recommends this method now, but it just goes to show how far Marcus will go in the name of medical science.
That's both impressive and disturbing, Crash. Let's stick to more conventional diagnostic methods, shall we? Now, as we come to the end of our Uber School production on renal pathology, what's one final piece of advice you'd give our listeners?
Great question, Pete. My final advice would be this. Remember that the kidney is not just a filter, but a complex organ involved in numerous physiological processes. Understanding renal pathology requires a solid foundation in renal physiology, so don't just memorize facts. Strive to understand the underlying mechanisms, and most importantly, keep your clinical skills sharp. The best nephrologists are those who can integrate their knowledge of pathology with astute clinical observation. And who knows, maybe one day you'll be as good as Marcus Cooper, minus the urine tasting, of course.
Well said, Crash. And on that note, we'll wrap up this Uber School production on renal pathology. Remember, future doctors, every kidney has a story to tell. It's your job to learn how to read it. Keep studying, stay curious, and we'll see you in the next episode.